Hi everyone, this is Neil Wrighter, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And this is a really difficult and complex case, primarily due to how narrow this patient's ear canal is. They have attended previously on a couple of occasions, and they suffer from eczematous otitis externa. So otitis externa is an umbrella term given for an infection or inflammation of the ear canal. And specifically with this patient, they have eczema in the ear, which results in a high turnover of dead skin. And because of the unusual high turnover of dead skin, this skin fails to naturally migrate out of the ear, and it collects in the ear canal. And I suspect also due to the fact they've got such a narrow ear canal, this dead skin becomes quite mushy. Particularly deeper in the ear. This is not too bad, this region. I have put some medical grade olive oil spray to help coagulate it a bit deeper in the ear, up against the eardrum. It's extremely mushy. They have seen ENT in the past regarding this issue, but it's more managing it and having regular clearance of the ear to keep on top of it. I am using our smallest size specular just to gain access. This is a 3.5 millimeter speculum. I'm using our standard 14 gauge suction probe, also typically known in the UK as a Zollner, and you can see there's very little space to maneuver in there. To the right you can see the second bend. They have got quite a bendy ear canal, so beyond this, and actually in a moment you'll have a bit of appreciation of just how bendy the ear canal is. When I start to remove this, you'll see the wax, it starts to hide behind that second bend, so the ear canal veers off to the right quite sharply. And then later in the video I'm using the specular to straighten the ear a little bit more so we get a full direct view. I actually normally book this patient in for a longer appointment because in the past it's been really difficult to remove, and it's the first time I've used the WAXscope. Actually, I thought, let's challenge myself and use the WAXscope in a really complex case. But although the wax is still quite soft, it did coagulate a bit better. So the main difficulty is it's just the lack of maneuverability. You can see that the suction probe, you can't really wriggle it too much, particularly left and right, because if you do, you're going to collide with the canal wall, which would be really uncomfortable. Obviously with this, it's going to be very difficult to remove with an ear hook or correct, because this is how narrow the ear canal is, gaining access with an instrument like that. And forceps obviously is not suitable because of the consistency. So I'm just straightening the ear a bit more. You can see more of the wax now, and the second bend is still visible, but it's more to the right. So I'm just going to the bottom initially, just giving it a little wriggle as much as I can. And then we're going to go to the top, and I'm probably going to use a bit more olive oil on a couple of occasions. At the end of the procedure, I actually went back in with the endoscope just to make, because you'll see there's a lot, because of the consistency, the mushy consistency of the wax, it's all stained against the eardrum. And I just went back in with the endoscope to see if there's anything more that I felt I could possibly remove with an endoscope, and I wasn't able to. And actually, at the end of the video, the eardrum, with the WAXscope, it does give a good illustration of the orientation of the eardrum. So the eardrum is not a flat disc at the end of the ear canal. It's got an oblique orientation. And what I mean by that is in their right ear, the top left-hand corner of the eardrum is what we call the posterior superior quadrant, is positioned closer to the eardrum than the bottom right area of the eardrum. So we call that the anterior inferior quadrant. And in the middle of the eardrum, where the hammer bone attaches to the eardrum, we call that region the umbo. The eardrum is pulled in, it's almost like a dimple there. It's retracted, and it gives the eardrum a unique shape. You can't always see it with an endoscope, and the best way to visualize the natural oblique nature of the eardrum is when you're using an ENT operating microscope, for example, because it has, you get depth perception via binocular cues, which is a bit more acute at viewing that angulation of the eardrum. But with the WAXscope here, we actually did get a good view of the oblique nature of the eardrum. Obviously, it depends on the individual patient of how oblique their eardrum is. Normally about a 45-degree tilt. So you can imagine the top left-hand corner of the eardrum in the right side. Obviously, if it's on the left ear, it's the top right side. But in the right ear, the top left-hand corner of the eardrum is typically, and the bottom right-hand corner of the eardrum. So that if you have a diagonal line from the top left to the bottom right, and if you have a side-on view of the eardrum, it's about a 45-degree tilt forwards from the top left-hand side of the eardrum. So you can just see how narrow it is. I'm just going to try and squeeze in. That's the eardrum. So you see the top left and even probably the left-hand side of the eardrum. It's more closer to us. Hopefully you can see that as well, to the bottom right. So I went in with the endoscope just to see if I can mop up anything more, if it was possible with the endoscope, but it's not. It's just a little sticky wax staining on the drum, which is fine. The eardrum is fully visible. The sound can go through. Well, I hope you enjoyed that video, guys. Oh, and we don't want to use water in that ear because they suffer from otitis externa before anyone mentions that. Take care, guys.